Hello, it's midday at London, reporting from Great Ormond Street Hospital for Children, once again with this monthly edition of Meet the Clinicians, Learn from the Clinicians. I think we have been working in silos for too long within radiology, trying to learn from Google and trying to learn from our books, trying to learn a little bit from the clinical case discussions, but this was a unique opportunity to get some real big stalwarts, especially in our hospital. And Mr. Richard Bowman, who joins us today, consultant ophthalmic surgeon, with special interests across the realms of pediatric ophthalmology, but particularly in strabismus, as well as neuro-ophthalmology. And he studied medicine at Cambridge University, and that's inspirational in itself, one of the top-notch places in the world, and subsequently at Guy's Hospital Medical School. He works across many hospitals within London, particularly the Moorfields Eye Hospital and the big neuro-ophthalmology setup that we have at Great Ormond Street Hospital in London. Richard also has done a stint of an observership at the Mayo Clinic, so he brings a wealth of experience from pretty much across the world. And it's a great honor to have him here today. Listen out to exactly what we miss out in the jigsaw that we play in radiology all the time. All we look at is a scan and we try to make sense of everything, but this is just a part and a figment of the jigsaw or the quiz that we're trying to solve in our day-to-day practice. So Richard, thank you so much. And you're going to help us kind of put the picture together today. Things like OCTs and, rICPs and bits and pieces that we don't know about, and how it kind of makes it relevant to your practice, and finally benefits the outcomes in terms of the patients that we deal with. And in this case, we're talking about children. So thank you, Richard. You're live at the moment. You're being watched and listened to people across the world. So please feel free to share the screen and get on with it. I will see you at the end of your time here.
Okay, well, thanks very much for inviting me. It's a pleasure to join you. And as Kish said, I'm just going to make this very clinical and case-based and show how some of the imaging that we do as ophthalmologists interacts and helps with the imaging that you do as radiologists, with some illustrative cases. And the first case is the longest one, actually, because I think it illustrates these interactions nicely. But it was the only one with a video which I thought was patient identifiable. So as we're on YouTube, I want you to pretend that I'm a 3-year-old boy looking at the TV screen, and I'm doing this. I hope you can see that. So a horizontal head shake. So now I'm going to share my screen and start the presentation. And let's see if this is going to move on. There we go. So this, as I say, was a 3-year-old child who's sitting at home doing this horizontal head shaking all the time. Now, this child has already had squint surgery because he had a convergent squint, slightly reduced vision. And because he had a bit of nystagmus as well, and sometimes you see head shaking with nystagmus, but this was a really marked head shake. And was causing a bit of worry. So he'd seen a neurologist, he'd had an EEG, and he'd had an MRI, all of which were reported as normal. And his squint got better a bit, but this head shaking persisted. In fact, it got worse. And one of the tests we do as ophthalmologists is called the visual evoked potential, where we sit a child in front of a TV screen and flash up either a flash of light or a pattern, a black and white checkerboard, and we measure what's going on in the visual cortex. And that's called the visual evoked potential. And it's useful for assessing visual acuity in children who can't report their visual acuity. But it's also good at looking at asymmetries between the hemispheres, between the left and the right occipital lobe. And those can occur with hemianopias, and they can occur particularly with chiasmal problems. And this child, when he had the VEP, showed what's called crossed asymmetry, which points to a chiasmal problem. And you all know that if you stimulate the left side of the visual field, because of the chiasm where the crossing over occurs, you get more stimulation in the right occipital field. And we have a trick of doing this between the two eyes separately, because you get more nasal stimulation when you flash the light in front of one eye. So if you compare the two responses between the two eyes, you can pick up what's called this crossed asymmetry. and you can pick up chiasmal problems. And this child had the VEP signs of chiasmal problem. So we decided to scan him again. And sure enough, he had this fairly typical cystic lesion, suprasellar, suggestive of craniopharyngioma. No sign of chiasmal compression, but nevertheless, quite an obvious craniopharyngioma. I'm going to ask, I will ask Kish at various stages to intervene and talk about the scans, but Kish, you're free to chip in at any time when I show a scan if you want to. So we went, and then another classic feature of craniopharyngioma is calcification on CT scan, which he had. And so we went back and had a look at the first scan, which had been done elsewhere. And sure enough, although it was smaller, you can see this lesion there and diversion of the pituitary stalk. So it had been missed. And so he was diagnosed with a craniopharyngioma and he underwent surgical treatment. And then he had proton therapy in Florida. And that's his post-operative appearance. And one of the ways we might pick up chiasmal disease as ophthalmologists is looking at the optic nerves, because if you compress the chiasm, you often see optic nerve pallor, but he didn't really particularly have optic nerve pallor. That's quite a subjective and variable sign clinically. So we can now measure the thickness of the peripapillary nerve fiber layer to look for thinning and optic atrophy, even if it's not obvious when you look at it. But he didn't have that either. You can see his nerve fiber layer thickness is within normal limits. You can't always do it. He had nystagmus, so we couldn't get an accurate reading on the other eye, just to show you it's not a perfect technique. Now, what was interesting, though, this is the same technique, optical coherence tomography, through his macula, his fovea. And what you see here in the cross-section is nothing. There's no foveal pit there at all. And this has nothing to do with the craniopharyngioma. So what's going on here? Just a little diagram to show you what the fovea should look like. You have quite a deep pit here. This is the central part of the retina responsible for most accurate vision. And there's a variety of conditions, classically albinism, but there's a variety of other developmental conditions of the eye where you get hypoplasia of the fovea and complete absence of the fovea in extreme cases. I put these pictures up because they just nicely show you how we can segment the retina and get very detailed views of the different retinal layers here. And here are the different cells that we're looking at with this diagram on the right. And just a reminder, we have the photoreceptors, which actually transform light energy into electrical energy in the outer part of the retina. And the inner part of the retina, we have the ganglion cells with their nuclei here, which then have the long fibers, which form the optic nerve all the way up to the LGN and the thalamus. So here we have a child who we found has got a craniopharyngioma because our VEP suggested chiasmal disease. But when we look at his retina, we find something completely different. And foveal hypoplasia also can sometimes be shown up on our color imaging of the retina. I don't know if it's coming out well enough here, but there are, I don't know if you can see concentric circles at the fovea there, which are sometimes a pointer towards it. Oh, here we are in higher magnification. You can see these concentric, and you can see there's no sort of dark dot at the center of the fovea here. And this is just again illustrating how detailed a view of the retina we can get in a different condition completely. This is the fovea again, but this is a macular hole showing how the vitreous is exerting traction on the retina and pulling a hole in it. But back to this case, what's going on here? Because what has the foveal hypoplasia got to do with the chiasmal pathology? And the answer is albinism, because in albinism is a chiasmal problem as well. And instead of what you get with compressive problems, where there's not enough crossing at the chiasm, which you get with a craniopharyngioma or a pituitary adenoma, compressing the chiasm. With albinism, you get too much crossing for some reason. In some way, the melanin is responsible for directing crossing at the chiasm. And what's ironic is that the VEP technique in young children can sometimes pick up the fact that there's a chiasmal problem, but it can't pick up whether there's too much crossing, as in albinism, or too little crossing, as in something compressing the chiasm. And that's because of the vector of the signal that you get from the primary occipital cortex, which is what we're picking up with our electrodes. And sometimes the vector goes this way, so the response from the left occipital cortex is picked up with the right electrode and vice versa. So with young children, you sometimes can just say there's something going on at the chiasm, but we don't know which it is. And it's likely here that we picked up albinism completely coincidentally with the VEP, which prompted us to go back and rescan, which picked up a chiasmal tumor as well. And we'll just say a quick word about how chiasmal pathology might present in children. Children with albinism often have a regular type of nystagmus, but actually this you can just see, I've maybe cropped it too much, but the nystagmus here is asymmetric between the two eyes. I'll move on because that's not come out very well. So asymmetric disconjugate nystagmus is pointed towards a neurological problem. And this is the classic form of nystagmus that you get with chiasmal disease. It's called seesaw nystagmus, where the eyes are going like that. And that's a classic pointer of chiasmal disease. We, as ophthalmologists, I've already mentioned, we may pick up optic atrophy or pale optic discs from chiasmal pathology. And it often presents in a horizontal band pattern of atrophy because of the way the fibers from the whole retina insert at the optic nerve. And I've shown you how we might pick that up with OCT, and I've shown you the detailed segmentation of retinal layers that we can get. And I've mentioned the ganglion cells, which are the cells that form the optic nerve. And this is a kind of heat map showing the thickness of the ganglion cell layer in the retina. And in the normal retina up here on the left, you have a thickened sort of donut area of ganglion cell thickness around the fovea. And this is a child with another chiasmal tumor with bitemporal hemianopia, bitemporal field loss, showing this hemianopic pattern to the ganglion cell thickness on these heat maps. So it's very exquisite detail that we can begin to pick up brain pathology by looking at these segmented layers of the retina. Just a reminder of the clinical features of craniopharyngioma. I was taught as a neuro-ophthalmologist, if you see an overweight child in your waiting area, they've either got idiopathic intracranial hypertension or they've got craniopharyngioma. And if they're asleep, it's craniopharyngioma because it can affect the hypothalamic function and make them sleepy as well as overweight. So he's a very interesting case, that child, where he was almost picked up by a very rare coincidence in having two forms of chiasmal pathology, one which resulted in too much crossing of his optic nerve fibers and one potentially too little from compression. So that showed an example of a radiologist who'd missed something, missed a small chiasmal tumor initially, but obviously radiologists are not the only people that miss things. And there's an infamous and tragic case which hit the news headlines because an optometrist was charged with manslaughter after a child died suddenly at school, I think, and was found on post-mortem to have a brain tumor. Then they worked out he'd been to the optician a few months earlier and nothing had been picked up. And they actually had fundal photographs and retrospectively found that papilledema had been missed. And I'm not sure of the details, whether the wrong photo had been looked at or it had just been missed. But because the optometrist ended up charged with manslaughter, it caused a huge impact in the news. And it's resulted in a huge number of referrals of children with funny looking discs into eye clinics throughout the country. And someone put a comment about how we might approach this on the listserv a couple of days ago, on the paediatric listserv among UK paediatric ophthalmologists, and there are already 50 replies to it, because so many of these children are coming in. Because a lot of children have slightly funny looking, slightly swollen looking discs, but don't have true papilledema. And it can be quite difficult to tell them apart clinically, although there are clinical clues that you can see even on these two images. So although this edge looks quite blurry, the retinal vessels are all nice and clearly shown, whereas this side on the left, which is true papilledema, you've got obscuration of the retinal vessels. And again, though the edge is blurred, the peripapillary nerve fiber layer is relatively spared here in this pseudopapilledema case, whereas here it's thickened and grey. And you can often see hemorrhages in true papilledema as well. But some cases are not as obvious as these two extremes, and it can be difficult to tell them apart. There are various causes why a child might have a swollen looking disc, but not have true raised intracranial pressure. Drusen is one of them. And I've mentioned some of the clinical features that we use. And children with pseudopapilledema often have anomalous branching their vessels as well. But what we'd like is an imaging of the eye that could give us the answer, is this true or pseudopapilledema? And we don't have that at the moment. And that would probably save you having to look at a lot of unnecessary MR images on children because of this worry about missing papilledema. Let's just go through some of the imaging available. So the optic nerve drusen are waste products from dying axons. We don't know what causes it. The nerves seem to be a bit small and crowded, and they're also often calcified. So you do the CT to look for the brain tumor because you think they have papilledema, but you pick up a calcified drusen instead. And calcified drusen can also be picked up nicely on ultrasound. We can also look for distension of the optic nerve sheath on B scans. And 30 or 40 years ago, it was reported the lateral gaze test, where if you've got a distended optic nerve sheath from raised intracranial pressure, when you look laterally, you'll get a compressive wave in the optic nerve because the muscles are attached to the optic nerve at the orbital apex, and you'll get a narrowing of the sheath on lateral gaze. But we do find it quite helpful to measure the width of the optic nerve, but it has to be done in a very systematic way with the same distance back from the optic disc. But that can be a helpful test for us. This is a B scan again showing giant optic nerve head drusen very clearly in this instance. Autofluorescence. Often these optic nerve head drusen are buried within the nerve, and you don't see these nice clear autofluorescent images. So it's not usually as easy as this, but that would be a giveaway that this is drusen, not papilledema. OCT, the technology I showed you earlier to look at optic atrophy and foveal hypoplasia. People have looked at whether we can qualitatively look at pseudopapilledema with this kind of lumpy, bumpy internal division here, and a fairly severe cutoff to the hyporeflective space under the disc there, compared with true papilledema, where you have a smoother contour and a bigger extension of the hyporeflective space, reflecting the spreading out of the fluid into the peripapillary nerve fiber layer. That can sometimes be helpful, and we can see distension of the Bruch's membrane in raised intracranial pressure. It can be distorted forward, and that this paper shows an example of that before treatment and then after treatment, where the Bruch's membrane comes back. And we can see the drusen themselves with the extended depth imaging OCT. You can actually see drusen themselves. So we're getting better at being able to look at an optic disc and say whether it's true papilledema or not. A gold standard test is to inject fluorescein into a vein in the arm, and then you can see the blood vessels in the retina light up. And if you get leakage from the disc, then that's a sign of papilledema. But that's quite an invasive test to do. You can get a child to swallow fluorescein, but so far that's not been very accurate in distinguishing from papilledema from pseudopapilledema. Well, as we're doing an imaging talk, I'm just throwing in a few examples of the same type of imaging for a different pathology. So this is also a fluorescein angiogram, and this shows peripheral closure of the vessels in the retina with a condition called familial exudative vitreoretinopathy. But you'd see a similar pattern with retinopathy of prematurity and a number of other retinal vasculopathies. So again, it's a nice way of imaging retinal vessels. I mentioned it's a bit invasive to inject a child with fluorescein or even get them to swallow it because it's pretty nasty. And there's an angiography version of the OCT technology that we've been looking at, but it doesn't show leakage in the same way that fluorescein angiography does. And this is a recent paper showing a true papilledema, describing a tangled mess of capillaries compared to normal discs or discs without papilledema. And it may be that we will be able to use this non-invasive technique. Maybe if we get enough cases and put it through some new artificial intelligence program, we may be able to pick up clues from this OCT angiography. So that's something for the future. Now, one group of children that we see a lot of here, and we're often asking the question, are their discs swollen? Are they slightly swollen? I hope you can see this is even prenatally. This is a child with a severe syndromic craniosynostosis where the skull bones have fused early and the orbits are too shallow. This is a case of Pfeiffer syndrome where all the cranial sutures have fused. This is the nice kind of 3D CT imaging of the skull that Dr. Mankad and his colleagues do at Great Ormond Street to guide the craniofacial surgeons. And I mean, it's easy to see what happens if you think about a single suture closure. So this is closure of the sagittal suture, and you get growth of the skull abnormally parallel to the suture that's closed early. But in children who've got more than one suture closed, we worry about raised intracranial pressure causing papilledema and visual loss. And the mechanism by which these children get raised intracranial pressure is not just a simple matter of the skull's closed early and it's too small and the brain's too big for the skull. There are a number of different factors that contribute to raised intracranial pressure in children with this type of multi-suture synostosis. We won't go into details now. But one of our jobs then is to, the surgeons could operate to expand the skull on all of these children, but it's quite invasive surgery, quite a high complication rate if you do it in very young children. So they, like us, to monitor for signs of raised intracranial pressure, because the main pathology that results from chronic raised intracranial pressure is visual pathology. So that's why we can not only see signs of it with papilledema, but we're the ones where we'll get the pathology in the vision if it's left. And we have a variety of ways of doing it, some of which I've already mentioned. But one of the ones that Great Ormond Street is known for is this VEP again, which we've talked about already. And we've just got a paper being reviewed by Eye at the moment, which shows that responses to pattern VEPs are more sensitive than disc changes at picking up changes in intracranial pressure in these children. And we did this on a group of children that had monitoring, direct surgical monitoring of their intracranial pressure. So we knew what the pressure was. And even one VEP reading was more sensitive, almost twice as sensitive as papilledema, and changes in serial pattern VEPs, 80 to 90% sensitive for picking up raised pressure. So this test is a non-invasive way, a good way of monitoring these children. We've got a PhD student who's looking at whether we can use OCT even on the small children. And for the OCT, I've shown you a few images now. You do need to keep still and look at a target light. So it's difficult for young children to do this, especially if there's things like nystagmus there. But there's a handheld version that Soab, our PhD student, is showing you here. And his project is to look and see whether we can use this to pick up raised ICP in these young craniofacial children as an additional way of doing it. I mentioned that visual loss is the main thing we're concerned about, and our predecessors audited the visual results for children with syndromic craniosynostosis, and 40% didn't have driving standard vision in their better eye. So this is not a trivial problem. Has our intensive monitoring of these children, doing all these VEP tests, OCT tests, refracting them carefully, has that made a difference? Well, again, we've had a paper just accepted in eye, which is a re-audit 16 years later, and the proportion who don't have driving vision has gone down to 25%. So we have improved things, but still, that's not ideal. We've made a difference with intensive monitoring, but there's more to do. It's not just raised intracranial pressure and optic neuropathy, but they have shallow orbits. So the globe may prolapse and the cornea may get exposed and dry, as these slides show. This was a child that had recurrent globe prolapse. And the other thing that's interesting for me as a squint surgeon is that the orbits are excyclorotated, as you can see from these diagrams. And that creates interesting motility problems. So this cartoon attempts to illustrate that. So this is a normal lateral gaze with normally positioned orbits. And then if we excyclorotate them, which hopefully will happen. Here we go. So this is the excyclorotated position. So the superior rectus is up here. Then as they do lateral gaze, you get upward and downward motion of the eyes as well. And that's a typical clinical picture looking at these 5 positions of gaze here. And this actually mimics inferior oblique overaction, because the inferior oblique is the muscle that elevates the eye when it's looking in at the nose. So that creates unusual problems for us as squint surgeons. Also, the superior oblique, you'll remember, is on a pulley, and with a shortened orbit, that affects the vector of the action of the muscle. And again, that contributes to these complex motility problems. Sometimes you get a nasty surprise. There is actually absence of the muscle when you get to operate on these children, as shown here, an absent superior rectus muscle. Okay, so that's raised intracranial pressure and craniofacial children in particular. I'm going to finish off with a mix-up of cases that I think have interesting imaging, either neuroimaging or ophthalmic imaging, just to give some variety. So this is a 12-year-old boy who started losing vision in the middle of last year. And by the time he actually got to an optician in December, he was down to 660 and 636, which is close to the top of the optician's chart. And his behavior was changing and his personality. Then he got a left-sided facial droop. So it won't come as any surprise to you that he warranted an MRI scan. And I'll maybe ask Kish to briefly comment on this.
Yeah, sure. This is a scan which was done at baseline at presentation. And what we have here, Richard, is extensive subcortical signal abnormality. It's taking off the white matter in a big way, but in parts it hits the cortex as well. And within the texture on the T2, you can see a degree of heterogeneity, and it's tending to cross over from the corpus callosum in the anterior aspect. So asymmetrical, mostly white matter distribution.
Yeah.
Very interesting pictures on the diffusion. There was a bit of restricted or reduced diffusivity in parts, particularly involving the anterior aspect of the caudate as well as the edge of this lesion. And we also picked up a little bit of contrast enhancement on gadolinium administration specific to the cortical folds around there. So putting this picture together, I think radiologically in the beginning of time, questions to you, back to the clinicians would be, is the child encephalopathic? What has been the presentation? But we're looking at a very white matter inflammatory process, and ADEM would be a likely differential on radiological basis.
Yeah. So it's in a way, a classic presentation of ADEM. Thanks very much, Kish, with encephalopathy and visual loss due to optic neuritis. And his disc showed mild temporal pallor, and he was treated with IV methylprednisolone, but his vision has remained quite poor over the last month or so. There's the temporal pallor showing with thinning of the temporal part of the peripapillary nerve fiber layer on OCT. And again, remember we said that there should be a nice donut of ganglion cell thickness around the fovea, and he's lost a lot of that due to this optic neuritis. And he was unusual in the fulminance of his clinical picture and his MRI. Just a quick word about the VEP responses in demyelination. 20 years ago, there was a kind of important finding that you can pick up a delayed latency in the VEP response with demyelination. And as we know, the natural history of vision in optic neuritis is to get spontaneous recovery, although some children, as this case is illustrating, don't get that. Steroids may speed up the recovery. And you can do a more detailed form of electrophysiology called pattern electroretinogram, where you can actually tease out the responses of the ganglion cells as opposed to the visual cortex cells. And if you're in the N95 pattern, which is a negative response at 95 seconds, that's where the name comes from, is the ganglion cell response. So you know if that's gone, then you've got ganglion cell death. But if it's still there, then you may just have demyelination and you may have recoverable vision. So that's an interesting, in fact, I'll show you the clinical relevance of that in the next case or in a future case. But even that name, N95, illustrates the point that electrophysiology is very good at temporal discrimination, because we know what the timings that visual signals hit different parts of the pathway is quite consistent between different individuals. But as the first case illustrated, it's not as good as the test you do at spatial discrimination. So combining the two together can give us the best information about what's going on in the visual pathway. And here's another case that's caused us quite a lot of worry. These are quite recent cases that have just been on the ward in the last couple of weeks. This was a 7-year-old girl who had a 2-week history of headache, fever, blurry vision, swelling of the left eye. She had a history of precocious puberty and being overweight. And she had, initially she had no papilledema, but she had fixed dilated pupil. She had signs of 3rd nerve palsy and 6th nerve palsy. And she had an MRI as well. Kish, do you want to?
Yeah, sure. This was an interesting case. And so what we picked up essentially was a lot of enhancement in the cauda-equina nerve roots. And then we looked upstairs in the brain and we picked up some cranial nerve enhancement as well. And some of these select pictures are showing you that in the anterior aspect of the cauda-equina. And when we see this, the instant knee-jerk reaction essentially is for people to think about GBS and GBS-like presentations, including the Miller fissure as soon as we pick up some cranial nerve enhancement, particularly ophthalmoplegia. I'm not sure if this case had ophthalmoplegia. We also looked at the COVID status of this child, because COVID, one of the manifestations could be a GBS-like presentation, but we didn't find that. So yes, a bit flummoxed with the final diagnosis on this one.
And why we were worried was that so the opening pressure on the first LP was 62, which is extremely high, and the child did develop disc swelling after that. And the first I heard about this child was I was being asked whether we should do optic nerve sheath fenestrations, because was the disc swelling due to this raised pressure, or was it due to demyelination? The other cranial nerves are highlighting up, as Kishan's just showed you. And furthermore, she was beginning to get better neurologically, except for her vision, which remained very poor. In fact, I never had to address the question whether to fenestrate her optic nerves, because she had a lumbar shunt done the same day, because they were worried about this high pressure. And when she had the lumbar shunt in, and that's a useful operation to do when you've got high protein in the CSF, because a shunt can get blocked. So that's why they do the lumbar shunt as an acute measure. So her pressures came down, her intracranial pressure came down with the lumbar shunt, but she still had swollen discs and still had visual loss. And even though she was getting better generally, her vision remained and remains very poor. And still we had this question, is this a pressure response or is it demyelination? Because she was being treated with high dose, she'd had plasma exchange, which is the first line treatment for a Guillain-Barré type syndrome, and now she's on high dose IV methylprednisolone. She's getting a lot of distressing visual hallucinations that some of the neurologists thought were due to the steroids. And if her visual loss is due to papilledema, the steroids are not doing any good. But if she's got an ongoing inflammatory optic neuritis, then these steroids might be the only chance she's got of recovering vision back. And some of the neurologists wanted to start rituximab as well. Yeah, so I've mentioned all this. So clinically, she's improving except vision. And so when I was being asked the question, should we carry on with high dose steroids? Should we elevate to rituximab? Two things made me in favor of treating inflammation. One was that her optic discs still look quite pink, whereas if they'd been destroyed by really high pressures of 60 prior to presentation, usually you see quite rapid onset optic atrophy. And also because her pattern ERG, her N95, that response that I told you that is related to the ganglion cells, was still present. Even though her pattern VPs were quite low, consistent with her reduced vision, she had a good N95 response, which made me think there are still functioning ganglion cells there. So they tailed off the steroids gradually, and they have started rituximab. She's improving a bit. She's improving a bit. She was 0.6 at 30 centimeters last time we checked her vision. She had a brain biopsy done because she did have a VP shunt eventually, and that confirmed evidence of demyelination going on. So she's an unusual case. We don't know exactly what the diagnosis is, but nevertheless interesting. A couple of motility cases now. Again, neuro-ophthalmology type cases. So this is a 13-year-old, previously fitting well, 1 month history of lethargy and struggling, and then facial change again. Sounds a bit like the first case. This child has good corrected visual acuities and no RAPD, but slight right facial asymmetry. She's complaining of double vision. And I just want you to have a look at her eye movements here. So she's looking to the right now, but you see the right eye doesn't go to the right, only the left eye does. Now she's looking to the left. She's got nystagmus in the left eye on lateral gaze, and I'll just play it again. when she looks to the left, the right eye has quite a poor adducting movement. So there's lag of adduction there. So that's a classic right-sided internuclear ophthalmoplegia and a right-sided sixth nerve palsy. She can't move her right eye, right or left, and the left eye has obvious nystagmus on abduction. The classic site of that lesion is the medial longitudinal fasciculus in the pons, which links the third and sixth nerve nuclei. Kish, do you want to tell us what you found here?
Yeah, sure. This was an interesting recent case, and this is a key image where we look at the facial colliculus being affected on the right side, and it's the location of the colliculus, so we are expecting to see some cranial nerve involvement. One wonders how much an imaging can show really, because there might be some signal abnormality extending just about to the medial longitudinal fasciculus, but within the limits of resolution of imaging, we can't be completely certain of that. But clinically, you're showing a very strong case of a 1.5 syndrome, isn't it?
Yeah, yeah. And you could see the facial weakness, but I cropped the video because of the YouTube. And I've seen her since, and her eye movements have improved significantly now. She's moving the eyes much more freely and just has a little bit of double vision on right gaze. And again, that's an example of the improvement that we see with demyelination. Now, here's a child who's looking straight ahead in this image and is looking to the right in this image and to the left in this image. But what's happened? Absolutely nothing. So this is a bilateral horizontal gaze palsy. And this is a child I saw a few years ago, but I've just diagnosed another example of this rare condition in the last couple of weeks at Great Ormond Street. Look, the vertical movements are intact, but there's no horizontal movements. And the other bit of the history is that this child has a progressive scoliosis. And here's the scan, Kish.
At your disposal, sir. This is select images, axial T2s at different levels of the brainstem, and sagittal. Now there's a purpose for the sagittal. So what we see here is almost a clefting at the medullary level, and also the pons in the back of it. And this is what is referred to as butterfly configuration of the medulla. This is a particular malformation. We'll come to that in a moment. But when you look at the sagittals, there is also the evidence of scoliosis, which I think you allude to clinically, but that's more of a clinical call.
Yeah.
You can see that there is subtle disfoliation of the cerebellum as well. You can see the vermis has got a bit of an overgrowth happening there in the superior aspect. These are underreported phenomena in this particular mutation, but very typical morphology on brain imaging.
Yeah, thank you very much. And this is a confirmed genetic Robo3 mutation with an unusual mutation. Actually, the lab in Boston have been in touch with us trying to recruit this child's study. And it's a gene that is involved in neuronal migration and particular control of crossing the midline, which explains the horizontal gaze palsy, but not so well this progressive, quite severe scoliosis that they get. So that's just a reminder of the clinical features of this condition. Just some orbital ones to finish off with, really, because I think you want a little bit of time for any questions. Where's the globe here? The answer is this. This is a microphthalmic eye with an orbital cyst, and it's just an example of how big the cysts can get. And it's mainly inferior, so it's smaller in the superior part of the orbit on the axial view. And the treatment for this one, because it was such a big cyst, this is my colleague, Miss Sri Gore, who's kindly contributed these images, was to do sclerotherapy to reduce the volume of that cyst significantly, leave the globe intact, and put these conformers in to try and help the orbit and the socket to develop normally. And the child will have surgery for definitive removal of the cyst at a later date. And this is a child that Srigor and I operated on together quite recently. And we started off the cases with one where radiologists had missed the diagnosis. This is an example of the opposite case where we went ahead with very disfiguring aggressive surgery for a tumor based purely on the radiologist's call without any biopsy evidence, which is very rare. But this is was diagnosed as a cyst in the orbit prenatally and initially neonatally, but changed clinically in terms of the proptosis. There's the clinical appearance there. And radiologically into a more heterogeneous solid tumor that was, and we consulted widely around the country, and the consensus was this could only be a teratoma, really, and it was progressed. There was evidence that it was progressing towards the orbital apex and the brain, and the joint decision from everyone was to go ahead with exenteration, which is removal of the whole contents of the orbit. And when we did this, there was CSF leak because the posterior canal was so expanded, and we had to patch it. Here's a surgical picture of the removal of the tumor, and we had to put in a orbital graft a few days later, but that's taken well, and child's doing well, and there's no post-op radiology shows complete excision of the tumor. This is, I think, probably one of the last cases, if not the last case, that Kish and I have been puzzling about. We're sent up from Plymouth. This looks like what we call a morning glory disc, named after the morning glory flower, which is a kind of cleft or a defect in the posterior wall of the globe, and can be associated with subretinal fluid exudating, and can be associated, you probably know, with a range of intracranial abnormalities like moya-moya or transphenoidal encephalocele. So it's quite an important thing to pick up. This child presents with poor vision in one eye and this highly unusual fundal appearance, which makes us think of a morning glory disc, but could be something called a combined hamartoma of the retina, which you sometimes see in children with NF2. So those would be the two clinical calls on that. And Kish has kindly looked at these images which were done elsewhere, and he pointed out that it wasn't necessarily typical of a morning glory disc because of enhancement. So I've gone back and looked at what's been published on the MRI appearance of morning glory disc, and this paper shows that there is this defect in the posterior wall of or a break in the let's see if it's a break in the posterior coats of the globe, and abnormally enhancing tissue in the distal portion of the optic nerve, which was shown on this image to be containing fat. So I don't know, Kish, would you still say that this one is atypical? I mean, it's difficult to see a break in the posterior wall of the globe there.
So the point to make with this one was, first of all, we were looking at this little hump or bump there, and it's also enhancing on contrast. There is a bit of a breach posteriorly. You can see that on the picture. So you can see why it would give you the morning disc appearance. What we don't know is the nature of this particular lesion. Is it a retinal hamartoma or a tumor of some description? Because there was nothing else in the brain to call it anything else. So that's the kind of unfilled space of the story. But you can see why this would give you a morning glory disc.
Yeah. And this child's had, you can get subretinal fluid leakage around the morning glory disc, and this child's had a retinal detachment and a scleral band to treat it. And that's it. Thank you very much. 10-1, so that's all right. So there's time for questions if anyone wants to ask questions.
That was awesome, Richard. Such a visual treat and really kind of puts the puzzle pieces together. And for radiologists to actually look at retinograms and the OCT pictures is it's great. There is an interesting question that's popped up here. I guess it's from Matt Wheeler, one of our fellows. And he says, when evaluating patients with suspected IIH, how much weight do you place on some of the various neuroimaging features? And I was going to ask you the same question. How do we image raised intracranial pressure, in other words?
Yeah, well, I mean, this has been sort of slightly controversial area. So there was a study on adults with IIH versus controls of about 20 patients at the Mayo Clinic, which did show these signs. And I think, if I remember, in order of sensitivity was posterior scleral flattening, tortuosity of the optic nerve, protrusion of the disc, and empty cella. I think those are the kind of soft signs that we look for. But we've got another PhD student at the moment who's looking at IIH as a condition, and he's trying a new form of electrophysiology to see if we can look at visual field changes more peripherally. But at the same time, we're getting, I think he's recruited the largest series of children that will form the largest series in the literature when we get around to publishing. And we've got deep phenotyping with MR imaging, a lot of electrophysiology, OCT on a lot of them. So I'm hoping that we'll be able to write the definitive paper to answer that question in children as to whether the soft signs. I mean, when I came here, the most experienced neuroradiologist before Kish joined said, it's rubbish. You don't see anything on an MRI scan. And when I spoke to Dr. Gordon Plant, who's the adult neuro-ophthalmologist, very eminent next door, he said, one thing's for sure is that IIH patients never have a normal MRI scan. So there's a wide variety of opinion on it, and it'll be nice to try and put some evidence in there.
I think there is a bit of a guideline piece being written at this point in time, but it will be a matter of looking at as many scans as possible.
Yeah.
And it becomes relevant in the context of the venous sinus changes that have been proposed as a mechanism or an outcome from raised pressure.
Yes. Yeah.
Right, Richard, whilst we are kind of heading towards the hour here, I have a question for you, which is a burning issue in my head, and it's about optic atrophy. Radiologists tend to call optic atrophy on MR based on some assessment of the slenderness or kind of the thickening of the optic nerve. But I think there is a very poor correlation between the optic nerve as it looks on MR versus what it does functionally. What is your experience, and do you think OCT or assessment of the retinal nerve fiber thickening is actually a better metric of that, and we should stop bothering ourselves with causing more trouble in your world?
Well, I think probably, to be honest, the OCT is more accurate. But we're always, the first question that we have whenever we see a patient with optic neuropathy is this compressive? Because that's one of the things that is most urgently need of treatment. So we have to scan anyway. So we're not going to stop scanning these children. And I mean, anecdotally, I find your comments on the slenderness of the optic nerves pretty well correlates with what I'm finding and what the OCT finds. And the same is true with optic nerve hypoplasia, which I didn't talk about, and is not atrophy, but it's just underdevelopment and small size of the optic nerve. And we all know that also is associated with upstream CNS problems, midline problems often. So again, they will at some stage need a scan probably, although nowadays we try and delay the scan to avoid an unnecessary GA and monitor their endocrine status. So again, I guess that's something that we would need to measure accurately, do a comparison study with the with the MRI width versus the. I mean, how standardized is it? Can you put a pair of calipers on a scan and come up with a standardized measurement?
I wouldn't want to put a pair of calipers on anything if I can avoid it, because it all depends on what make of the caliper you're using and what you're putting it.
Yeah.
For many things in radiology.
Yeah. Well, I think the answer is yes. OCT will be more accurate, but we're not going to stop imaging them because we always need to exclude the most, the most urgent cause.
Great. One of my final questions to you, in fact, two. One is a thought and one is a question. But I'll share my thought with you first. We've often had discussions about where are the extraocular muscles, or should we do a CT or an MR and 3D reconstructions. There is a bit of useful information that you need for squint correction that we are not able to effectively offer you because we are not able to resolve the exact attachments of extraocular muscles. Now, anyone in the audience listening in or the posterity that would be watching in on YouTube, if you want to share your thoughts with us, I've been wondering whether there is a possibility of doing a bit of a dynamic MR study on the extraocular muscles. Has anyone attempted any of that? Are we able to actually look at these muscles in real action time with a fourth dimension called time resolved imaging? And I'm just working on that in my head. But if you have come across any literature, would that be something useful, Richard, for us to work on?
Yeah, definitely. There is some work on it with the imaging of the pulleys in time, but probably not with the high resolution capacity that we've got available now. So that's a good idea.
Great, something for the future. And I think it's always good to leave these things on a bit of a futuristic note. Thank you very much, Richard, for the 1 hour that you've spent with us and the radiology community. I think this is one of the most comprehensive talks on orbital imaging one could offer, because we should not be restricted to MRI and CT, but we have to look at the entire picture, as we keep telling our fellows and residents.
Yeah.
So, I will hopefully see you in the corridors of the hospital soon. Until such time.
Well, you said all those nice things about me. I should say that Kish is very supportive of the eye department, and we have regular monthly meetings where he not only helps us with our diagnostic conundrum, some of which you've seen today, but also teaches our fellows, and it's a very great collaborative relationship we have.
Thank you for the endorsement, and I think that's a bit of a reminder that we have one coming up on Monday.
Monday,
yeah. All right, Richard, thank you so much.
Thanks very much. Bye.
And thank you, everyone, for logging in and listening in. Bye-bye from Radiologists Hospital.